All right, thank you so much. So let's go. 2024 Internal Medicine Paper 1. Question 1 is saying a 70-year-old right-handed man with a history of atrial fibrillation and hypertension presents with sudden onset right facial droop, right arm and leg weakness, and word finding difficulties. On examination, all the following clinical features are expected to be present except A. Able to close his right eye and furrow his forehead symmetrically. B. Visual field defect in the right hemifield. C. Right leg much weaker than the right arm. D. No features of neglect. Any thought on this one? If some, let's just analyze the symptoms. So this is, say this is a person. Of the symptoms that the features that we've been told, there is sudden onset, right facial droop. So the right side, which one? This side. Okay, there is a facial droop there. And then right arm and leg weakness. So these two sides are weak. And then word finding difficulties. Now we know the area that controls the speech. We have got the Broca's area, right? And that's mostly on the left side. So if there's a problem on the left side of the brain, it's actually going to present with weaknesses, motor weaknesses on the right side, right? So that's the information that we have. So now we want, on examination, all of the following clinical features are expected to be present except which one? Able to close his right eye and furrow his forehead symmetrically. Visual field defect in the right hemifield. Right leg much weaker than the right arm. No future neglect. Any thought from anyone? Okay, thank you so much. Yeah. So if you look at the first option, because as we've already said, since this patient will not be able to find words, it means likely the problem is actually on the left side. So that's why they're finding difficult to find words. And then the weakness is on the right. The problem is on the left side. And specifically, where you are expecting to find a problem will be in the mid cerebral artery that supplies this area. We're going to find the Broca's, right? So when you look at the other features mentioned, the A is saying able to close his right eye and furrow his forehead. Of course, he can close his right eye. The eye is going to be okay because the control of the eye opening closing, that is we are going to be looking at the posterior aspect, isn't it? The posterior or the occipital lobe, specifically for sight, vision. But of course, we also have the control of the opening of the eyelids, but this is specifically for vision. And then the forehead, they can furrow the forehead. We know if you are, because we are saying if it is the left middle cerebral artery that is affected, there will be an upper motor neuron lesion. And for an upper motor neuron lesion, like in stroke, someone can wrinkle the forehead, but they will just fail to the just the lower face is going to drop. B is saying visual field defect in the right hemifield. Now for the visual field, the defect can actually get to happen because when these fibers cross from this one eye and the other one, the fibers are going like that. These fibers are actually going to be able to pass. They'll be able to cross the path of the fibers can also be affected on the way. Specifically, this is going to be the visual field defect in the right hemifield. If we say hemifield, remember we can split this one like this, and then we can also split like this. So what happens if this, the way I've drawn it, okay, let me put it like so. Okay, so this side is the right hemifield, and also this one, this side, this is also the right. So you can see the right hemifield or the right eye, the fibers will be going to the nasal field and then go to the opposite eye. So you can see both fibers actually ending up going to the other side. They are both going to the left side. And the left side, that is where also the effect is on the, in this case, we're saying the mid cerebral artery. Now for A, it was close, yeah, closing the, able to close his right eye. The closure of the eyes is not concerned with the fibers that are carrying this vision. Closure of the eyes is something different, where we are talking about the eyelid in that case. So these fibers are specifically for sight, the ones that will be passing through the region that is also supplied by this mid cerebral. And then for this saying no features of neglect. Now neglect is not, is actually normally affecting the, when someone has got neglect, normally the side that is affected is the right side. So if the right side is the one that is affected, neglect is normally on the left side. So they are going to neglect most of the parts on the left. For example, if they are brushing or if they are cleaning themselves, on, they'll forget to clean their left side. So it's more common on the left because the most affected artery is the one on the right. So because here we are saying the effect is likely on the other side, we don't expect neglect in this case. Okay. Number two is saying a 55-year-old male chronic smoker with hypertension presents to the emergency room complaining of 6 over 10 substernal chest pressure that started 1 hour ago. While watching TV, the pain is stuttering in nature, lasting for 2 to 5 minutes at a time, then subsiding. He had two similar episodes in the past. His BP is 162 over 95. The rest of the examination is normal. After, after aspirin, sublingual, nitroglycerin, morphine, metoprolol, and oxygen, his chest pain stops. His ECG is normal and cardiac enzymes are negative. The remainder of his labs are normal. What is his primary diagnosis? Now, for the first question, the answer is this one: right leg and much weaker. So this one is an exception. So if there is an effect on one part of the brain, as in this one, where we're suspecting the mid cerebral artery, both sides of the of the limbs, I mean, both upper limb and lower limb will actually be equally affected. Yeah. So I hope we've gotten what has happened on this question too. So we have got this patient that is watching TV and then they develop this pain. Remember, they are dressed. They have got now this pain, which is a busteno. Actually, it is pressure, which started 1 hour ago. And then there's also pain that is stuttering in nature, lasting 2 to 5 minutes at a time, subsiding. And then when they take some painkillers, the pain is actually relieved. And then the ECG is normal, cardiac enzymes are also negative, and then the remainder of labs are also normal. What is the diagnosis? Unstable angina, chronic stable angina, gastroesophageal reflux, non-ST elevation, myocardial infarction. Any thought on this one? All right, thank you so much. Yeah, likely this is unstable angina. Now, when we are talking about, remember, we have this, we have what we call coronary artery diseases. These coronary artery diseases can either be acute or chronic. Chronic is also known as stable. Okay, so for the stable coronary artery disease, this is where we find what we call stable angina. And then for the acute coronary artery diseases, this is where we can divide them into two. We have got those where there is ST segment elevation and those where there is no ST segment elevation. So no ST segment elevation. Where there is no ST segment elevation, we have got what we call non-ST segment elevation myocardial infarction. So non-STEMI, any STEMI. Okay. We also actually have the unstable angina. And then for the ST segment elevation, we have got STEMI. So conditions that fall in what we call acute coronary artery diseases or ischemic heart disease, we have got a three: STEMI, non-STEMI, and unstable angina. And then you need to differentiate how these guys happen. Okay. So the way they happen, when you look at a blood vessel, here I'll draw it cross section and also like that, the longitudinal. So unstable angina, what happens is that let's say there is a plug somewhere, and then this plug ruptures, and then it goes and at a specific point obstructs blood flow to an area. So what happens in that case is that at that particular time, you are going to experience these chest pains. Okay, so there's going to be typical chest pain because of an emboli or the rupture of a plug. But the ECG is going to be normal, echo is going to be normal, the cardiac enzymes are also going to be normal. So what really happens in unstable angina is there is simply ischemia, no blood supply to the heart, but there is no injury. So that's what we need to take note of. There is ischemia, but no injury. And then when it comes to the non-STEMI, non-STEMI is actually going to occur because of partial occlusion. Let's say, for example, you have got an atherosclerotic plug, okay, that is like this. It is still here, and this makes a partial occlusion in the vessel. But so there is just a reduction in blood flow to the area, but of course there is blood flow still. So what happens in non-STEMI is that there's also going to be chest pain, but it is slightly severe in comparison to the unstable angina. Okay, and here the cardiac enzymes are going to be elevated. Specifically, when we're talking about cardiac enzymes, which one are we talking about? We are talking about CKMB and also the troponins, like troponin I, troponin C. All right. So the cardiac enzymes are elevated, but then the ECG and the echo is normal. Now, when you look again at the non-STEMI, there's going to be ischemia, but injury can either be there or it cannot be there. When you're talking about STEMI, it is actually going to be total occlusion of the vessel. The entire vessel has been occluded. And so here, this is going to present now with typical severe chest pain, which is substernal. It can actually spread to the neck, to the jaw, or even to the left shoulder. And here, the cardiac enzymes are going to be elevated. The ECG is also going to be abnormal. There's going to be ST segment elevation, specifically greater than or equal to 2 millimeters in at least two leads. Echo is also going to be abnormal. It's actually going to show what we call hypokinesia, like slow movement. And then here there is ischemia. At the same time, there's also injury to the muscles. Okay, so those are the three diseases in acute coronary artery syndromes or ischemic heart disease. Number three is saying a 75-year-old man is brought to the emergency room after his wife found him unresponsive on the couch. He has background of chronic knee pain and is on several opioid painkillers. Vitals show respiratory rate 6. So basically respiratory rate is depressed. Blood pressure is also low, 90 over 50. Heart rate is 60. We can say that is low. Of course, the normal is 60 to 100, but this is the very on the normal end, the lower normal end. And then the oxygen saturation is 80%, only 100% non-rebreather face mask. So, in other words, oxygen saturation is still low even when someone is on a face mask. On examination, is comatose with mottled core extremities, poor respiratory effort, and no gag reflex. His heart rate is regular with no abnormal cardiac sound and the 3D peripheral pulse. Chest examination is normal, although his breaths are very shallow and slow. His pupils are pinpoint with equal deep tendon reflexes bilaterally. Which blood gas findings would be most consistent with the patient's presentation? Respiratory acidosis and hypoxemia, respiratory alkalosis and hypoxemia, metabolic acidosis and hypoxemia, mixed metabolic acidosis and respiratory alkalosis and hypoxemia. Any thought on this one? Anyone? All right. Thank you so much. So when you look at the features that have been presented here, the patient initially was taken, remember, his wife found him unresponsive on the couch. He has a background of chronic knee pain and is on several opioids. So these features comatose, pinpoint pupils, uh, severely depressed respiratory rate, shallow breathing, even hypotension and hypoxia. Because how do we say, how did we tell this hypoxia? There is you can see the oxygen saturation is low even on face mask. So these are features of opioid overdose, right? So likely this patient has developed acidosis. By looking at the oxygen saturation is really low, and then when you look at the other features, depressed respiratory rate, it means that they are actually having failure to remove the carbon dioxide from the body. And what happens in that case is that the carbon dioxide is going to be accumulating in the body. That can cause them the respiratory acidosis. Okay. And at the same time, there's going to be a lot of carbon dioxide in the body which will be in blood, that's known as hypoxemia, or there is not going to be oxygen delivery to tissues. So that is hypoxemia. When you look at respiratory alkalosis, in alkalosis, what happens is that the patient is going to be breathing very fast. And when there's hyperventilation, what is happening is that you are removing a lot of carbon dioxide from the body. What happens that you only remain with a little carbon dioxide, and little carbon dioxide means that you have got because carbon dioxide can actually react with water in the presence of carbonic anhydrase to form carbonic acid, and this carbonic acid will break down into hydrogen. So that is acidosis. So when you have got low carbon dioxide because of hyperventilation, you will now develop respiratory alkalosis. But you can see here there's a depressed respiration. And then for metabolic acidosis, when someone has got metabolic acidosis, what happens that there's going to be respiratory compensation. So you start breathing out very fast because in metabolic acidosis, you actually have a lot of hydrogen. So this hydrogen will be reacting with the bicarbonate to form carbonic acid, which will further break down into carbon dioxide and water. This carbon dioxide will go to the lungs, and then you start breathing out very fast so that you can remove it. So in metabolic acidosis, again, just like in respiratory alkalosis, you are going to be breathing fast, but this is a compensation. Okay, so that's why the best option here is going to be A. Number four is saying which statement concerning malaria is correct. Malaria caused by any of the four species of Plasmodium can relapse after initial infection. Repeated bouts of malaria infection can result in massive splenomegaly. Plasmodium falciparum causes an immune mediated nephropathy. Renal impairment is a grave prognostic sign in Plasmodium falciparum malaria. Any thought on this one? Anyone? Okay. So please feel free in case you want to get to explain the answer, why you choose such an answer, right? Doc, do you want to explain why you picked D? So remember, we want what is correct concerning malaria. When you look at A, malaria caused by any of the four plasmodium species can relapse. This is not true. Relapse is only because of those guys that show hip. What do you call these ones? Hips, I failed to pronounce that. Hypnozoids. Hypnozoids. Yeah, those are the ones that are going to show relapse, and specifically that is ovale and vivax. For malaria and Plasmodium falciparum, those ones can undergo what we call recrudescence. Like after treatment, they might not be totally cleared, and so they can come back. But hypnozoids, these are guys that were hidden in the liver and then they can come back later on. B is saying repeated bouts of malaria infection can result in massive splenomegaly. Now, the statement can be true, but now what causes the massive splenomegaly in malaria is because of the chronic disease. Not really repeated bouts, but if the infection has been there for long. C is saying Plasmodium falciparum causes immune mediated nephropathy. Yeah, Plasmodium falciparum is going to cause AKI, it is going to cause kidney injury. But now, specifically, this kidney injury is going to be because of injury to the, what do you call that? To the not really the immune mediated. The immune mediated kidney injury is specifically caused by Plasmodium malariae. Plasmodium falciparum is also going to cause an injury to the kidney, but it is via the tubular necrosis, acute tubular necrosis, right? Not as an immune response. So that's the difference between the kidney injury caused by falciparum and the one caused by malaria. Number five is saying a 65-year-old man so the answer there is there. So if 65-year-old man is hospitalized for surgery, he has a history of hypertension, diabetes, benign prostatic hypertrophy, hyperlipidemia. His prostatectomy is uneventful. He is on ibuprofen and morphine for pain. On on day two post surgery, his catheter is removed. The next morning, he complains of abdominal pain and he has voided very little urine. His vital signs are temperature is 37, heart rate is 100, respiratory rate is 16, BP is 150 over 90. What is the next correct course of action? Replace the indwelling urinary catheter, order an abdominal ultrasound, measure urine and serum electrolytes, discontinue morphine, and giving high volume resuscitation IV fluid. Any thought on this one? Okay. A. Yeah. So remember this patient, what has happened is that they are having complaints of this abdominal pain. You had removed the catheter. Remember, the catheter was there, but on day two, the catheter was removed, and then they are only voiding little urine. So the best thing that you can do for them is, since they are not voiding urine, help them to void urine. Remember, acute urinary incontinence can be very, very painful, right? So you want to make sure that by all means, unless you can't, but by all means, try to make sure that you help relieve them of the urine. Okay. And then the next question, a 26-year-old woman develops a red rash over the cheeks and pain. Oh, sorry. A 26-year-old woman develops a red rash over her cheeks and pain and swelling in both wrists, as well as several small joints in her hands. The rash gets worse on sun exposure and involves her cheeks, nose, ears, and chin. Medical evaluation reviews oral ulceration and 3 plus proteinuria. Which of the following is the most specific test for diagnosis of this condition? Okay, what do you think is the condition here? What's the diagnosis? Yeah, more likely systemic lupus erythematosus. So, what is the most specific test? Antinuclear antibodies, anti-Smith antibodies, antro antibodies, and phospholipid antibodies. Any thought on this one? Okay, yeah, the anti-Smith are really, thank you so much. So these guys are really, really the most specific, right? Yeah. Anti-nuclear antibodies are also very good, but the only thing is that for those guys, they are more of the anti-nuclear. Those are very, very sensitive, but not really specific. In other words, nearly everyone that has got lupus and nuclear antibodies will be positive. So they are best used for screening other than for diagnosis because they can also be positive in other conditions. Same with the antiphospholipid antibodies and the antro antibodies. They are also in lupus, but they can be in other conditions. Like for example, the antiphospholipid antibodies they will be in antiphospholipid syndrome. The antro antibodies they can also be in Sjogren's syndrome. Number 7, a 32-year-old woman presents with heat intolerance, palpitations, diarrhea, weakness, and weight loss. Her blood pressure is 90 over 60, pulse is 110 per minute, and she has a fine tremor in her hands. The thyroid stimulating hormone level is suppressed. T3 and T4 are elevated. Which of the following is most likely to precipitate this condition? Pro, Propyuria uracil administration, high dose prednisolone therapy, beta adrenergic blockade, pneumonia. Any thought on this one? Okay, why do you go for pneumonia, doc? Any thought? Why? All right. Okay. Thank you so much. Yeah. So when we look at this, the hypothalamus will produce thyroid releasing hormone, stimulating the pituitary to release thyroid stimulating hormone, and then that will cause the thyroid gland to release T3 and T4. Now, if you give any drug that is going to increase T3 and T4, or any condition that is going to cause an increase in T3 and T4, what happens is that by negative feedback, these are going to go and start reducing TSH. And this is what has happened. TSH is suppressed, meaning that T3 and T4 are high. Now, propyluracil and the high dose prednisolone, these guys, even beta adrenergic receptor, these guys are going to be using the treatment for hyperthyroidism. For the adrenergic, the beta blockers, you actually use them to treat the heart manifestations like the tachycardia in hyperthyroidism. Okay, but then for for a condition like the thyroid storm, where you have got this acute rise in the thyroid hormone or the acute release of the thyroid hormone and then showing symptoms, there are many precipitants. Some of those precipitants include surgery, infections, and pneumonia is a possible infection that can precipitate this condition. Okay, so if someone says thyrotoxicosis and thyroid storm, what's the difference? So thyrotoxicosis is just a clinical syndrome where I've got high levels of thyroid hormone. But now thyrotoxicosis is actually a life-threatening, it's an emergency where there is an exacerbation of thyrotoxicosis. And the thyrotoxicosis will be gradual. Thyroid storm is a sudden rise because of a certain trigger. The trigger can either be an infection, surgery, trauma, childbirth, withdrawal from the antithyroid medications. Okay. And then again, when you look at, because in thyroid storm, you can have infection, so you can have high grade fever there, you can have vomiting, diarrhea, abdominal pains, and then you can have severe tachycardia and also marked tremor. Of course, tremor also be there in just in if hyperthyroidism or thyrotoxicosis. The BP in thyrotoxicosis is usually elevated because that's what the thyroid hormone does. It will increase the basal metabolic rate. But in thyrotoxicosis, what will happen is that you actually, it will progress. Instead of it being elevated, someone is going to end up going into shock. So they become hypotensive. And I think that's what we can even see from this question. The BP is 90 over 60. That's low. So that is the thyroid storm. So thyroid storm is a medical emergency. Someone should be in the intensive care unit. And then for thyrotoxicosis, basically give the beta blockers, the anti-thyroid drugs like the same PTU. You can give carbimazole and those. Okay. Number 8 is saying, so what have we said the answer is there? The answer is pneumonia. Number 8, a 34-year-old man presents with symptoms of fatigue, weakness, nosebleeds, and palpitations with exacerbation. With exertion. On examination, he is pale, BP is 110 over 70, pulse 100 per minute, heart sounds are normal, lungs are clear, and he has multiple petechiae and bruises. Does petechiae present in reduction of platelets or reduction in clotting factors? Which one? Okay. Yeah, clotting factors. What are you likely going to find instead of petechiae? Ecm- yeah, ecmosis, excessive bleeding in the joints, basically bleeding anywhere. That will also include, uh, including also just in the GI, and then there's going to be hemath blood in the joints. Okay, so we continue with our question. So I've got this patient who presents with fatigue, weakness, nosebleeds, palpitations on exertion, and then his pale, BP is 110 over 70, the pulse is 100, heart sounds are normal, the lungs are clear, he has multiple petechiae and bruises on his legs. His blood count is abnormal. HB is 8.5, white cells 4,000 per microliter, platelets 50,000 per microliter. There are blast cells on the peripheral smear. He is diagnosed with a promyelocytic leukemia, AML M3. Which of the following is a characteristic of acute myeloid leukemia, AML? What is the feature? Peak incidence in childhood, high leukocyte alkaline phosphatase, Philadelphia chromosome, or bodies in blast cells. Any thought on this one? Okay. Or bodies. Yeah, so this is one thing that is important for us to take note, all right? When you are talking about myeloid leukemias, you have got basically leukemias themselves. Leukemias, you have got the acute ones and then you have got the chronic ones. The acute ones will present with blast cells, and specifically, you are going to have greater than 20% blast cells when you do this peripheral blood smear. The chronic ones, the cells are going to be mature. Okay, the cells are going to be mature. Now, for the acute ones, specifically when you're talking about AML, the specific feature that you find here is going to be the OR bodies. They are so specific to acute myeloid leukemias. If it's chronic myeloid leukemia is going to present with a specific diagnostic feature is a Philadelphia chromosome, or there's going to be the ABLBCR gene mutation there. Okay, there will be a translocation between chromosome number 9 and number 22. That's the BCR-ABL gene. Okay, so specifically the chromosome 22 that is abnormal is what we call the Philadelphia chromosome. So that is really specific, so, which we need to take note of. When we are talking about the, because this is the myeloid ones, if we are talking about the acute lesser lymphocytic and the acute, the chronic lymphocytic, for these ones you are going to use, especially this one, you are going to use these tumor markers, no, not really the tumor markers, but what do you call that, cytogenetics, where you are going to be looking at the CD. Are those the CD? Yeah, the CD. I've forgotten that. Not, it shouldn't be the CD. Okay, it's actually the CD cell. Yeah, the CD. Normally, these guys are going to be carrying single digits, like for example, CD2, CD3, CD9. When you see these ones, you are going to be suspecting that's the acute. That should be the acute when you see single numbers. And then there's also going to be, what is it? The TDT. So these guys will also be TDT positive. I think that's the one. Yeah. So please take note of the myeloid ones, our bodies in acute, and then Philadelphia in the chronic. Number nine, yes, doc. Yeah. Okay. All right. Thank you so much. I've not just come across that. It's just one specific feature that I've known when you are looking at the acute myeloid leukemia. Thank you so much for that. Mm. So a 63-year-old. Okay. Yes, doc. Okay. Peak incidence in childhood. Anyone to help on that one? Yeah. Yeah. So for ALL, this is the one that is more common in childhood in comparison to the AML. This one is more in children. Okay, 9. A 63-year-old male reports to the emergency room with hematemesis. He feels fatigued and somewhat short of breath, although he is still able to speak in sentences. He has had some epigastric pain for the last few days, then suddenly vomited a large amount of bright red blood at home. He has a history of osteoarthritis, for which he takes ibuprofen. Vitals, temperature is 36.9, heart rate 115, respiratory rate is 20, BP is 90 over 50. Exam is unremarkable except for some mild epigastric tenderness on to palpation with black tarry stool on rectal exam. What is the next best step? So remember what we have here. This one comes to the emergency room with, there's hematemesis, there is fatigue, basically symptoms of should be anemia, shortness of breath, is still able to speak in sentences, he has had epigastric pain, and then suddenly vomited large bounds of bright red blood. He has history of osteoarthritis, and remember he was taking this bro here, ibuprofen. Okay, so what is the next best step? Type and cross is blood, then transfuse, cross match or blood. Bolus 0.9% normal saline IV. Place a triple lumen centrovenous line for resuscitation. emergency esophagogastroduodenoscopy. Any thought on this one? Okay. Okay, thank you so much, good doc. Yeah. So in this case, this patient has just vomited a lot of blood and they might actually be going into shock. So we don't want to waste time. Give them fluid before come and start looking at what is wrong, right? In that case, before you can even come to start doing the esophagogastroduodenoscopy. This is for that you want to find the diagnosis, you want to find what is wrong, right? So and then crossing and matching for blood transfusion before you can cross and do that you'll be waiting for the results for them to come so you can quickly give normal saline to help with the fluid loss in that case. Okay, number 10 is saying a 60-year-old woman with a history of hypertension and diabetes presents with sudden onset bilateral lower limb weakness that was associated with a severe backache. On examination, she has hypertonia, hyperreflexia, and 0 out of 5 power in both legs. She cannot feel pain or temperature up to the level of the umbilicus, but has normal vibration and proprioception. What is the most likely localization of a presentation? Are we able to see the screen? Okay. All right. Okay, so this is like the anterior spinal cord syndrome. Isn't it? Let's get to analyze the question. Here is Crichton. Okay, and for this bro, what has happened is that he comes with bilateral lower limb weakness. So lower limb, both of them, and then what else? Associated with this severe back pain, and then there's hypertonia, hyperplexia. So this is the weakness there, and then there's reflexes are high, tone is high, but the muscle power is low. He cannot feel pain or temperature to the level of the umbilicus. Okay, so meaning that here, down here, pain and temperature is gone. And remember, these two guys are carried by the anterolateral system, the spinothalamic, isn't it? Okay, spinothalamic or anterolateral system, pain and temperature. So meaning that this guy is in the anterior aspect of the spinal cord. So in other words, the problem is likely in the anterior spinal cord. And then we're also being told that normal vibration and proprioception. Vibration and proprioception is because of the dorsal middle meniscus pathway. Since it's normal, it means that the posterior aspect of the spinal cord is actually spared. So we can't pick A, we can't pick C because for C it actually affects both the anterior. Transverse spinal cord syndrome affects both the back and the front. And then bilateral anterior cerebral artery. Now, this is basically the cerebral artery. Uh, okay, I don't know how I'm going to disqualify this one. But when we look at they call it what, the homunculus, this part of the brain which controls the lower limb is the one, so that is supplied by this is the anterior, isn't it? Yeah, the anterior cerebral artery. This middle part that controls the lower limb, right? So if it's the one, if the anterior, if this guy is affected, of course we expect to find those symptoms of the lower limb being involved. But now, why are we going to disqualify in this case? Okay, let me hear from others who can help me. How are we going to disqualify D? If we are only picking, of course, anterior spinal cord syndrome is going to be true, but then why are we going to disqualify D?
So, I'm curious about everything. Like you said, the motor homuncular. This will be as well the video access of the photo, photo. So some ACA is affected. We expect that there should be weakness, but this weakness should be more on the leg than it is in the upper limb. Meaning that even on the upper limb, there should also be weakness. Only that it will be different more on the leg than more on the upper limb. But then this also should affect the face. In this case, this is bilateral, it also affect both sides of the body, which I don't think we see as a typical feature in this person.
Okay. All right. Thank you so much. Yeah. So just another thing to add what the doc has said. If it's bilateral anterior cerebral artery syndrome, as the doc has said, there's going to be lower limb weakness. But now with the also with the sensory, the sensation that has been presented, so more likely we are not going to present with sensory level dysfunction. That is specific with the pattern that has been given here. For example, where you are sparing the like where the sensation is only affecting below the what the this one they're saying below the umbilicus, right? Because that is so specific below the umbilicus, and for this one the sensation might have been a bit of more widespread than just being specific below the umbilicus. Yeah. Number 11 is saying which patient best fits the diagnostic criteria for hypertensive emergency. A 19-year-old male with severe traumatic closed head injury who is unresponsive with a blood pressure of 190 over 110. 65-year-old female with headache, confusion, papilledema with blood pressure 190 over 105. An 83-year-old male with mild chronic dementia and a BP of 210 over 105. 45-year-old male with 2 plus proteinuria and normal urea and creatinine with BP 200 over 105. Any thought on this one?
Okay.
Okay, why do you go for that one, Doc? So we define an hypertensive emergency as a life-threatening condition where the BP is greater than 180 over 120 and should be associated with acute, new, or worsening damage to target organs. So this part is very important. Besides you looking at the BP greater than 180 over 120, there should be acute or new or worsening damage to target organs. Okay, please just a moment.